Good morning. We have today genitourinary system. That means is genitourinary renal. Sometimes we just get mixed up. So genital area, urinary is renal. So it's a renal, we are going to talk about it. And I will go over on this, but I wrote it down here. Is a lot of tests. As I move on, very important that we got to know the test. Then on renal, if you know the renal, you have to connect your questions with your electrolytes. Because once your kidneys are shutting down, its effect on the lab. And what are the labs are very important here. Your sodium, your potassium, and your magnesium, your phosphate, and your calcium very closely attached to this subject. So when we talk about the kidneys, we are talking about their electrolytes. And then I will be using this word. So after I finish this part, I will move on. But remember, you cannot take any exam or you can function good as a nurse if you don't know our electrolytes. So remember, your lab is very important. So I wrote it down. Whatever you're reading, I have some other separate lab, but I wrote it down because you got to connect your question. Kidneys are bad, and they're going to throw your labs, and they will say, what would you monitor for your lab? Your potassium, your phosphate, your calcium is affected with your kidneys. So very important, we all know, if you want to write down, so when you're studying, you memorize. If you have exam cram book, you have lab there. I give also lab. Lab is very important with each chapter. So let's go ahead and start in renal system. First is the lab. I'm going to talk about it. I wrote it down, the urine analysis. When we are doing urine analysis, we all know we are collecting the urine. Can CNA help you to collect a regular specimen? Yes. But are you going to teach the CNA how to collect it? Yes, very important. You need a specimen and CNA collect from the urinary bag. That's a contamination. Are you collecting a urine specimen from bedpan? That's a contamination. You got to use directly a midstream specimen directly in the container if you're doing the culture. But collecting from bag and collecting from your bedpan is leading contamination. And when your urine specimen is contaminated, that means the bacteria are growing. And you won't know what is really infection and where are these bugs are coming. So number one, yes, CNA can help you, simple collection, empty the bag, yes, they do that. But remember, urine analysis. If they ask you a question, urine analysis, what would you see in urine analysis? Remember, urine is clear. Normally, it's clear, light yellow color, and if it is concentrated urine, always remember sign of what? Why is concentrated? Dehydration. What are you encouraging patient here? To drink water. Now, urine analysis, you can see the color, clarity, protein, glucose, ketone, red blood cell, white blood cell, microscopic pus. But what you cannot see here is bacteria. Everyone is okay? Patient has infection. What kind of urine are we collecting? Culture. You cannot see infection in urine analysis. Everyone is okay? In your question, pay attention. Urine analysis when we are doing what we cannot see, the bacteria. You want to diagnose a patient for infection, you got to do with urine analysis, culture, and sensitivity. Are we clear? So why do we do sensitivity? Is to see the infection and to see what kind of bacteria patient has. So we are looking urine analysis. There's no bacteria, but yes, for your bacteria, patient is having UTI, you got to do the culture. You can see red blood cell, white blood cell. You can see the color. You can see the other thing, protein you can see, glucose you can see, but for culture is to see the infection. That is very important for all of us. And remember, if your urine is contaminated, your culture is bad. And what happens if you contaminated all the time urine? What happened? We are wasting money, right? We have to pay the lab. So who is responsible to make the mistake? Us, as a nurse. So when your result come back and it says urine contaminated, and you see every time same nurse is collecting and it's a contamination, it doesn't show you're doing your job. So we must remember when we are collecting urine specimen, number one, a proper container, sterile container, and you prevent from contamination. That's why a lot of questions are, before you collect the urine specimen, what do you tell your patient? Wash the area, clean the area. That is more priority than you're saying collect the urine in midstream. So remember, we will go on urine analysis. In your pages, you have washed the perineal, anywhere, genital area work or private area washing. How much urine do we really need it for the specimen? 10 to 15 ml. We don't need to completely filled. Second line is important. When we are collecting urine specimen, where do you keep the specimen? In the refrigerator. Because if you're not sending right away and you keep it outside in the room temperature, the bacteria will grow. So where do you keep it? Like nursing home you're working. Patient is at home. Now we are teaching patient at home. Patient calls you in your question. Patient says, what do I do after I collect? Or what would you teach the patient to collect? Remember, number one, cleaning. Number two, remember, after you collect it, you keep it cold and you deliver the urine specimen to the lab in the morning. If you have fresh specimen and you can deliver right away, but do not leave it outside. You can keep it. But it does affect a little bit the pH of the urine. So question, urine analysis, how much urine you will collect it. Cleaning is important. Culture, you got to do to see the patient's infection. Number two is very important, is specific gravity. And what is the specific gravity depends how much we pee, amount of urine. I want you to write down there, you pee less and you pee more, all polyuria. When you pee more, your specific gravity is high. Is low. When you pee more, your specific gravity would be low. When you pee less, oliguria, a specific gravity would be high. Why? Because the urine is concentrated. And that goes in our endocrine system when we are talking about, remember, a specific gravity, ADH. Everyone write down a little word, ADH. What is ADH? Is antidiuretic hormone. It's affecting the urine output. If you pee more or less, depend on ADH. Your ADH is high, that means you are going to be, what would happen when you have too much of ADH? You will absorb more urine. Because what is ADH does? Absorb the urine. So remember, specific gravity is very important to see how your hormones are working, because polyuria, you have your urine is more clear and specific gravity is going to be low. When you have specific gravity with ADH is high, that comes the other disease is called, remember there are two diseases, SIDH and diabetes insipidus. Remember? So you got to learn connection. Your questions are not only just to know we are collecting, but what is in specific gravity we are looking if the patient has polyuria and patient has anuria, and what is the patient's specific gravity, and what does affected by is ADH. Are we clear? Either you're peeing more or you're peeing less. Number three is the culture. For culture, again, remember the word perineal area to clean. And second line is, third line we said is prevent contamination and drink fluid and midstream urine specimen. How can you collect for culture? So if they give you culture specimen, how do you collect the culture specimen? Number one, your patient is alert. You can tell them to do what specimen? Midstream specimen. Your patient is incontinent. How would you do incontinent patient? In and out catheter, straight catheter. You got to get a doctor's order. If you have a patient Foley catheter, you can collect it from the Foley catheter. So everyone is okay. How do you collect the culture? A patient is alert. You can give them the container and tell them to collect what? Midstream urine, a specimen. A patient is incontinent and you are in nursing home, confused, disorientated. You got to get an order for straight catheter and you put it in, collect the specimen. That's another way. Number third is patient has Foley catheter. Where do you collect the specimen if the patient has Foley catheter? Where do we collect the specimen on Foley catheter? Everyone remember, the word is called port of the catheter. So what do you do, port of the catheter? Clean it. And what do you remember is clamp the catheter. We got to clamp the catheter. Once we clamp the catheter, that means for 30 minutes, then the urine will drain. Because what is indwelling catheter is Foley catheter. Urine is coming out all the time. So when you're going to take out the urine, you may not get it. So question, how do you collect it? Number one, clamp the catheter. Clean the catheter. And that's important to prevent infection. A sterile syringe, a sterile container. So that goes in your sterile specimen and midstream specimen, and cleaning is important. And remember, always you can, if they have, remember, we have in exam all that apply. Some patients cannot pee, you can always increase fluid before you are collecting. That means let them drink some more water so you can get the specimen. Next one, test comes under creatinine clearance test. Creatinine clearance test, I want you to underline second line, blood sample and urine collected together. And what kind of urine we are collecting? 24 hours is underneath, and blood. When you start collecting, they draw the blood. So what is creatinine clearance test? They are collecting 24 hours urine and they draw the blood. Everyone is all right? Line where it says second one, blood sample. Then you go on 24 hours. Now you are collecting for creatinine clearance. Any question? When we are collecting 24 hours urine specimen, what do we remember? Three things are very important for us here in 24 hours urine specimen. Encourage fluids is good. Avoid coffee, and maybe sometimes some of the medication may be on hold. But very important in 24 hours collection specimen is discard the first specimen. What do we do? Discard the first specimen. Then you start collecting and keep them in ice or refrigerator. If you, in your question, you have ice or refrigerator, you pick up the best is ice, because a lot of places they don't have refrigerator. And if you do have refrigerator, you are keeping the patient's food and drink. So you can always take ice and put it in a wash basin, keep it in the bathroom, patients pee, and you pour in the container. Are we clear? So where do we keep it? The best is ice. If you don't have ice, and they said, where do you keep it? And you have no other choice than refrigerator, that's fine. Then you pick up the refrigerator. So remember, is the ice or refrigerator, both things you keep in mind. And the second line, a special container. What is the special container is the preservatives. They have chemicals in there. You can't take any bottle and we start collecting. There's a special container. So three things is important. Before you start collecting is you get the bottle and communicate with patient, nurses, your CNA, all shift, because you're collecting for 24 hours, and the family member, because sometimes you're not there, family member is there, and what they can do, they can discard the specimen. So as a nurse, you got to have a proper communication. Remember, communication is very important wherever we do our patients, whoever you need to let them know. So CNA needs to know. Next is the uric acid. Uric acid, when they're doing, they also collect 24 hours urine specimen. I wrote it down here. Everyone should know labs. Uric acid 3.5 to 7.5 normal, and uric acid goes high. Which patient would be uric acid is high? Gout patients, very good. And so gout patient, kidney problem, uric acid is high, encourage fluids, regular diet, there's no other problem. But we must know uric acid is collected for the kidney test. Maybe patient has gout, maybe patient has kidney problem. But yes, we must know the level. Very important that we know the level. I wrote it down. Next is vanilla mandelic acid test. Where do we do this test? That goes again, your endocrine system. It's called VMA. And which patient do we do? Very important, VMA is also when we are collecting, it's a 24-hour specimen. And what do we monitor here? Which patient, when they have diagnosis, is called phenochromocystoma. What is phenochromocystoma? Is adrenal gland. And what is adrenal gland? Part of adrenal gland, write down the word medulla. So medulla is the part of the adrenal gland, and that has a tumor. And what is it producing more? I want you to highlight the word catecholamine. So what are we checking in the urine? Catecholamine. And what is catecholamine is affecting? I want you to write down the word epinephrine. Epinephrine or norepinephrine. And what does it affect? The blood pressure. So another question, not only the test, patient is admitted with phenochromocystoma. What are you going to monitor? The blood pressure. And maybe your question, what is high here? Epinephrine. Why epinephrine is high? Because they have catecholamine. So write down the word catecholamine is high. And what is high here? Epinephrine or norepinephrine. Everyone is okay? So why do we do this test, VMA? To diagnose the tumor in adrenal medulla. What do you monitor for patient for adrenal medulla problem here, or catecholamine is high, or VMA? The blood pressure. Everyone make sure we add their blood pressure. Now when we are connecting, not only just memorizing the wording, but connect ourselves. Connect for your question. Your patient has a renal failure, or patient has a kidney problem, or here it goes in a patient who has in a adrenal gland question. But what are we collecting here? The urine specimen. So see how other part of the body we are checking with the urine here, and we said vanilla mandelic acid test. Then I said specific gravity. Specific gravity again, we are connecting with what? Endocrine system. Now, so those are very important. Everyone should know, when your kidneys are bad, what are you monitoring the lab? Are creatinine and BUN. And if you have both of them, BUN shows also dehydration, shows, but what is really affecting the kidneys are creatinine. So if you have both of them and you got to report, then you go for creatinine level. Then I wrote it down, some lab here, and after these lab, make sure everyone remembers on those testing. So next is, in vanilla mandelic acid test, avoid food is caffeine, cola, vanilla, and fruits at least for 2 days. Avoid medication 2 to 3 days, and avoid stress because of the blood pressure. And also you are collecting 24 hours urine specimen. Next test is called KUB. Underneath it says KUB. What is KUB? Are kidney, ureter, and the bladder. So what is in your urinary system is, we have 2 kidneys, we have 2 ureter, and the bladder. Patient is complaining pain. Maybe they're suspecting a stone. Maybe doctor has ordered to do KUB. So what is KUB? It's a simple X-ray of kidneys, ureter, and the bladder, and we don't have to do any specific preparation. Only you fill out a slip, call the X-ray, and you're going to do it. Next one is very important, is intravenous pyelogram. What is intravenous pyelo? I want you to remember the word. Whenever you see pyelogram, what is the meaning with pyelogram? Is inside the kidney. So what are we looking? They're giving a dye. Intravenous pyelogram, pelvis of the kidney. What are they looking? Inside the kidney. So immediately you see the word patient is going for IVP. What are you immediately? Patient is scheduled for pyelogram. They didn't give you the word IV and they said patient is scheduled for pyelogram. Immediately you know pyelogram is the pelvis of the kidney. Patient is going for kidney test. When you see the word gram, graphy, automatically you know they're going to inject the dye. So they're going to inject the dye and they're going to look inside the kidney. Very important, IV injected and they're looking for the renal. Now let's move to the next page. On next page, intravenous pre-op care. Very important that we know pre-op care. Patient is going, consent is important, allergies is important, number one is important, consent, and it's invasive procedure. And remember, the word is IV. They're giving IV. So what are they giving? Iodine. Are we going to check allergies? Yes, for iodine allergies. And also, next is they're going to give and keep patient NPO. Number 4 is very important. 2 and 4 very important for your question. Patient is scheduled for IVP. What do you do before patient is going for IVP? They didn't ask anything and they said, what do you give them? Enema. Why? Why do we give enema? Because our kidneys are where? Where are our kidney? In posterior, in the back. What is another word is called? Is in the, this is the front abdomen and is your in the back posterior. Are we clear? So patient has kidneys in the back. What would be interfere if all the intestines are full of BM? So you cannot see the kidneys in the back. So you remember the word, kidneys are in the back, and you have to give enema. You got to have your patient clean. A patient is not had an enema and clear, you will not get the good picture of the kidneys. And what do you tell when you give iodine? Anytime, graphy, gram, you're giving iodine. Number 5, flushing, warm, salty taste. 3 words very important. It causes flushing, iodine causes making patient feel warm, and what do they feel here? Salty taste. So what does the patient feel here? The salty taste. Next is void before the procedure and assess the pulses. Peripheral pulses you assess. Post-op care. What do you do after the procedure? Highlight the word. Is vital sign we all know. Remember, bleeding, because they are injecting. So wherever you're injecting, they can bleed. And CMS, color, you're looking, and also temperature, sensation, maybe apply the sandbag. After you give iodine, you always encourage fluid so the body would be clear faster. Everyone is okay? IVP is intravenous pyelogram. What do we do for intravenous pyelogram? Enema, I want everyone to remember. I want everyone to remember, check for allergies, flushing, warm feeling, salty feeling. After the patient come back, monitor for bleeding. Always encourage fluids. Renal scan. Patient is going for renal scan. Whenever they're doing any scan, they use, underline the word, radioisotope. And then they are giving them, and the third line is 24 hours wear the gloves when you're using for emptying the urinary bag or incontinency and standard precaution. And also use the double bag for contaminated the clothing and the linen. So renal scan, remember the word, any scan, they're going to use radioisotopes. And what do you monitor is radioactive, which is excreted by 24 hours and prevent the patient from contamination yourself, and use the double bag. So that goes in renal scan. Now you have renal biopsy. Anytime patient is going for renal biopsy, what would you remember is one thing, where our kidneys are in the back. So they're going to ask you the position before and after. So in renal biopsy, coagulation, anytime patient is going for any biopsy, you must check them clotting time, coagulation time. And if they have coagulation time is lower, that means maybe or higher risk for bleeding. Consent is important. Position, what position do we put our patient here? Is number one, in position, second line, prone position. Why do you put them on prone position? Because the kidneys are on the back. So what position do you put the patient during the procedure? Prone position. Everyone is okay? And maybe use the pillow under the abdomen. After procedure, what do we do? Monitor the vital sign. And also hypotension, meaning patient is bleeding. Tachycardia. And what do you monitor for the vital sign? Immediately bleeding. But what would be the position if you will go on third line? Now you turn the patient on supine, means on the back. And bed rest is important because risk for bleeding. So what position we are going here? Supine. What position we did before and during the procedure is the prone position. Very important, the position. Then you go, if fluid is okay, to increase fluid and to increase fluid so it clears the kidney, and monitor for bleeding and avoid lifting. Avoid lifting, and anything can lead to bleeding, pressure, and lifting anything can lead to the bleeding. So renal biopsy is important. We know renal scan word is radioisotope, biopsy position, prone position, and after the procedure, you will go on the back or supine or recumbent position. Next page, you have acute renal failure, and I missed it one, which is under renal scan on page 2. Cystoscopy, very important is cystoscopy. Before I go to the next page, I missed it, cystoscopy, so very important. What is cysto word is? What is cysto? Cysto means the bladder. Scopy means it's again endoscopic procedure. And what are they inserting here? The scope. And what are they looking here? The bladder. So consent is important. And who will do cystoscopy? Urologist. Is done by the doctor. Patient goes in a doctor's office. We are the nurses. We are going to help the patient to lay on the table. What position patient is going to lay when you're going to do cystoscopy is lithotomy position. Patient would be on lithotomy, and remember the word urologist, okay? Next is post-op care is monitor the INO. Sits back is okay to give them. Leg cramping is common. Patient complain having a leg cramping could be normal immediately after procedure because patient is laying in what position? Lithotomy. So that could be because of the position. But very important, we move on under post-op care. Is leg cramping. Then you go burning. Very important that you know burning. Normally, burning is sign of infection. Frequent urination, sign of infection. So underline the word burning or pink color or go on the T-colored or frequency. That is normal. Everyone is okay? Is frequency of urination or bleeding, or maybe they're saying pink color. If it is a bleeding and a red color, that means it's a lot of bleeding. Yes, normal is a pink color. Why? Because they have put the scope. Maybe a slight bleeding is there. So pink will be considered more normal. Then underline the word red color. When you have red color, you got to notify. See, a lot of questions are not we know, but understand the concept here. Now, when patient is coming back after cystoscopy, patient has pink urine. Now, don't think they're bleeding. Yes, they could have slight bleeding. Pink color is considered normal here. Now, which one are you going to notify? When they have bright red color, more red color is in the urine, then you notify the physician. Everyone is okay. Cystoscopy is very important for your exam. Biopsy, we all should know. Renal scan, we already talked. IVP, all are very important for your for NCLEX exam. Now, before I moved into acute renal failure, I want few wording here. Neurogenic bladder. What is the word neurogenic bladder? See, we are nurses. They're going to put the wording, so you're not only knowing the kidneys and procedure, you must know the word neurogenic bladder. What is neurogenic bladder is? Patient is not able to pee. Neurogenic. Where does neuro goes? Tomorrow, I'm going to do neurological chapter. I will be talking some of the diseases patient cannot pee. Why? Because of the nerve problem. Now, do you think this patient who cannot pee is okay to have a Foley catheter? Yes. So you don't want unnecessarily patient to have a Foley catheter. In your question, which patient is okay to have Foley catheter? Number one, your neurological problem. Or they use the word neurogenic bladder. Patient has spinal cord injury. What happened to them? The nerves are affected. They will not be able to pee. So what do they have? Foley catheter. Multiple sclerosis disease is affecting the brain and affecting the nerve. Patient cannot pee for 8 hours. You can try nursing intervention. And that is the meaning you can help the patient. Which patient cannot pee totally wherever you have the word neurogenic bladder? What do you assess? You are a nurse. What do you assess if you have in your question, patient has neurogenic bladder? What do you assess? What would you assess? Urinary retention. What are you monitoring? Bladder distension. I want you to write down that word too. Bladder distension or urinary retention. What is urinary retention is? They cannot pee. Remember, what is urinary retention? They cannot pee. What does it lead to when patient cannot pee? Urinary retention. What does it lead to urinary retention? Number one, UTI. They will have UTI. And what happened? Think about, they're retaining urine. And what will it affect to them? Septic shock. And then they're going into what? Shock, septic shock. And what happened in shock is their potassium level is going to be very high because of the kidneys. Are we clear? See how your questions are? We must know how to assess our patient. So what are we assessing here is neurogenic bladder word. What is neurogenic bladder? Patient did not pee. What do you assess? Your answer would be bladder distension. What are we assessing? Urinary retention. How do you know post-voided urine specimen? So patient is retaining here, and patient is going frequently to the bathroom in your question, and patient only pee very little urine at a time. That means patient is having what? urinary retention. Now you call the doctor, and doctor gives you order to check is voided specimen and post-voided residual. So what is the word is called post-voided residual. What is the word residual is left over. After patient pee, after patient goes to the bathroom, you insert a straight catheter. If the urine comes out 100, 150, what does it mean? Patient did not empty the bladder and patient is having what? Urinary retention. Everyone is okay? Everyone shouldn't remember the word post-voided residual. We are nurses. If they ask you, you are putting a straight catheter and you are collecting the urine specimen. Everyone is okay? Urinary retention, neurogenic bladder word. And what are we checking here? Urinary retention. Sometimes they will say bladder distension. How do you know patient is retaining the urine? We are going to do post-voided residual. How do we do post-voided residual? By straight catheter. After patient pee, 10-15 minutes, you go back, insert the straight catheter, urine comes out more than 50 ml. That means patient is retaining the urine. And what would be the risk here? What would be the risk? UTI. Are we clear? Renal failure. Patient keep on having. So what this patient can have? Foley catheter. Everyone is okay? Neurogenic bladder, because of the nervous system, the bladder has no sensation. A lot of your diabetic patient, they cannot feel for the urine, and they also start retaining. Your spinal cord injury patient, multiple sclerosis, that is when I will talk tomorrow about that, and the first thing would be for them are the urinary retention. Let me go into another question for you guys are bladder training. Anybody knows how to do a bladder training? Bladder training, number one, I want you to remember is there are two kinds of bladder training. If you have Foley catheter and you're going to remove the Foley catheter and doctor said you do the bladder training before you remove. So what do? We clamp the catheter for 2 hours. After 2 hours, you unclamp the catheter and for 15 minutes. Every 2 hours you are clamping. What are we doing here? Is bladder is getting strength to hold the urine. See what happened when you have Foley catheter, the urine is draining all the time and bladder doesn't have any control over the bladder. So patient gets so used to when you have Foley catheter and they're going to be incontinent. So before you remove the catheter, doctor said, I want you to do 24 hours is the bladder training before you remove catheter. Then what do? You clamp the catheter is for 2 hours, unclamp it until your order is completed. That means what are we doing? When we clamp it, the bladder fills up with the urine, and then when you release it, so we are doing is contraction and relaxation. So they are holding and you're giving is the exercise of the bladder. Now patient who is incontinent, how do you prevent? Another question. So this goes Foley catheter. You have 20 patients incontinent. You have a lot of incontinent patients. What do you do as a nurse in your question? Number one, maybe your Kegel exercise. Are we clear? Maybe your answer is bladder training. And what are you doing in a bladder training? Same is your Kegel exercise. Are we clear? And what is bladder training is? Number one, in your question, real problem when you're solving for your patient incontinency, you have to have a doctor's order. Everyone is okay? Number one, bladder training order you have to have from the doctor. So you have a doctor's order and you have a bladder training and how frequently you are taking your patient to the bathroom. Every patient is different. So never your answers can be every 2 hours. Maybe somebody needs every hour. Somebody needs every 4 hours. They're good, but they still need to take frequently. Bladder training, how frequently you're taking your patient for. So what is bladder training? You're taking them to toileting. Depends how many hours, every 2 hours, every hourly. And number 2 is you got a doctor's order. Yes, you have to write it down how frequently you're taking your patient to the toilet. And number 2, do you increase fluid or you decrease fluid? Always you're training your patient is increasing fluid. Patient says, I'm on a bladder training. I don't want to drink a lot of water. And you will do the question I gave you in Lippincott. And patient says, I don't want to drink a lot of water, otherwise I'll be wetting the bed. I don't want to wet the bed. Say no. When you are on this, you don't want to restrict fluid. So remember, in your question, what do you do in bladder training? Your answers are going to be, number 1, doctor's order. Number 2, remember how frequently you're taking your patient to the toilet. And number 3, remember increasing fluid. Next, are we going to put in the care plan? Yes. Nursing care plan. Update your care plan that you're taking. What is the patient's problem here? Incontinency. What are we planning here to keep the patient dry? What is your plan? Patient we are taking to the bathroom, how frequently? So update your care plan. Then what are we doing here? Next. See, these are your answers. And these are important. We are nurses. Every day you'll be taking care of the patient like this. Evaluation. And in evaluation, you have to have a form which CNA, who is taking to the bathroom, is filling it out. Are you communicating your CNA? Yes. You got to let the CNA know what is the plan. Where do you keep the form of your bladder training? Maybe a patient's bathroom, maybe in your record, maybe where CNA can document. So every 2 hours, whatever your plan is, your CNA brings back the patient and she will say, 8 a.m. I took the patient was incontinent. Or maybe in your coding you have wet. Or patient was 10 o'clock when you took patient was dry. So you're going to evaluate at the end of the day. When we took the patient to the bathroom, how many times was your patient was dry? How many times patient was incontinent? Are you going to see, is it working your plan or not? Yes? So think about saying one word. Bladder training doesn't cover your responsibility. We got to know what is really bladder training. You will see questions on that. So number 1 is bladder training, is your question, increasing fluid, updating care plan. Are you doing evaluation? Yes. Weekly, daily, you're going to, CNA will fill out. But as a licensed nurse, you're going to do weekly assessment. Last week, how many times did it work your patient? Now, every time you see patient has been wet, 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 are you going to continue? It's not working for your patient. Maybe you may have to try something else. Everyone is okay. Privacy, very important. Not discussing with family member, only the one who is legally responsible and patient. Are we clear? So HIPAA questions are there, and HIPAA is very important for your privacy. Whether someone is talking in the hallway or exposing your patient, HIPAA is not only for documentation, but maintaining the privacy. Everyone is all right on bladder training question. Very important that we understand, because how to do bladder training. Next is, the word is, I had here, is anasarca. What is anasarca word is here? Generalized edema. Kidneys are bad. Kidneys have generalized edema, and they throw this wording. How do you know your patient kidneys are getting better? Your generalized edema is getting better. Are we clear? So everyone should know the word. Yes, you know the word edema, preorbital around the eyes edema, and sarca word is generalized edema. Anuria word. Anuria. What is anuria? No urine output. And oliguria, less urine output. Urinary retention, we already talked about it. So very important that we all know your electrolytes. I'll leave that part. So anyone is writing, make sure we all know terminology for it. And now I will move on the next page. There is renal failure. What kind of renal failure do we have? We have acute and we have chronic. So I'm going first on acute renal failure. What is the meaning acute? What is acute word is? All of a sudden, kidneys shut down. Are we clear? That means patient never had a kidney problem. There is something going on with the patient. So patient is admitted, patient has acute renal failure, is underline the word precipitating word. What is the meaning precipitating? Something triggered. And what is precipitating? Burned patient. Patient got burned. Septic. Patient has septic infection. Kidneys are shutting down. Are we clear? Patient has cardiac problem. Patient kidneys are affected. So what is the meaning here? Acute renal failure, that there was something going on in a patient, now their kidneys are shutting down. Kidneys are having problem. So there has to be something else going on with the patient. And precipitating means something else. Maybe the heart is a problem, patient has problem with maybe spinal cord injury, maybe patient has a cardiac problem, patient is going in a septic shock, patient is in a burn, and patient's kidneys are affected. Everyone is okay? Acute means they never had any other problem with the kidney. And all of a sudden, kidneys are affected. And when they're saying in kidneys are affected, same thing in the burn patient. What is in the burn patient comes, first thing is oliguria. And what do we monitor when you have oliguria? There's low urine output. Very small amount of urine coming out. So 3 stages you have in acute renal failure. Number 1, oliguric stage. What is oliguria word? Anytime if they didn't give you renal failure and says patient has oliguric stage. What is oliguric? Low urine output. So what happened? They can throw the wording glomerular filtration. Where you says what is glomerular is, remember, glomerular is inside the kidney. In your anatomy we studied. And what is the glomerular does? Filter the urine. So write down, underline the word glomerular filtration means low urine output. So what is oliguric state? Low urine output. But we must remember oliguric stage means what is affected? Glomerular. What is glomerular does? Filtration of the urine. And so urine output is low. So what rate is lower here? Urine filtration rate is lowering down. That's why we have what is the urine output low. So as you understand the word oliguric state is glomerular filtration rate is low, patient has low urine output. What does all of a sudden increase when you have low urine output? Your BUN and creatinine is going to be high. Everyone is okay? What is high here? BUN and creatinine would be high. BUN and creatinine is high, and underline the word potassium. And that is why when we talk in the burn patient, and I say, what do you monitor in burn patient right away? The potassium level. Why? Because the fluid, what happened to the fluid is shifting inside the body. But here, when the kidneys are bad, you have what stage is here? Your filtration rate is lowering and you have less urine output. Immediately, your mind should say, what happened? Kidneys are bad, BUN is high, creatinine is high. What is high here? Potassium level. I want you, the word is, when you have low urine output, remember the word hypervolemia. What is hypervolemia? Means another word you will say, overhydration. Dehydration, less fluid. What do we have here is overhydration. We have too much of urine which is staying in the body. Are we clear? So what do we have here? Overhydration. Maybe the word is overhydration. Maybe the word is what? Hypervolemia. What does goes high here? Phosphate level. Phosphate level is high. And whenever I said in the endocrine system, phosphate level goes high, automatically your calcium level is low. Are we okay? So what is high here is potassium is high, BUN is high, creatinine is high, phosphate is high, but what is low here? Calcium. Another one question. Patient is in renal failure. What do you monitor patient with renal failure? And maybe answer would be low calcium level. And what does it lead low calcium level? Osteoporosis. Are you going to be protecting your patient from fall? Yes. And that is why, because their phosphate level is very high and calcium is low. And this runs in patient when they have acute renal failure about 2 weeks, 8 to 15 days. And then you start treatment and you start correcting burn for your patient, you start giving fluid, your kidneys start getting better. Are we clear? So what is the first stage of acute renal failure is oliguric phase. What is oliguric phase? Filtration rate of glomeruli are reduced and patient has low urine output. What happened? Filtration rate is low, kidneys are not filtering, and what happened when your urine is low? Your body is retaining fluid, and what is the word is called? Hypervolemia. And what would happen in hypervolemia? I want you where it says overhydrate, your blood pressure is going to be high. What would be the other problem? Is breathing, shortness of breath. They won't be able to breathe. See how your questions are going to be. Not all the time one, but patient has renal failure, and what do you monitor your patient? Everyone is okay. What is high here? We all need to memorize. BUN is high. Creatinine is high. What is high here? Potassium. What else is high here? Phosphate. What is low here? Calcium. And what is high here? Blood pressure. What our patient is having problem here? Whenever you retain fluid, hypervolemia, patient is not able to breathe. And what do they have? Shortness of breath. What are you going to assess as a nurse here is the lungs, and you are checking for lungs. Positioning would be here. So everyone is okay, oliguric state, in acute stage of the renal failure. Let's go diuretic. What is diuretic are? You are increasing urine output. That is diuretic stage. Are we clear? So patients start peeing more. Write down the word diuretic. Is patient is having more urine output. Diuretic means increasing urine output. Page number 3 in acute renal failure and diuretic phase. Diuretic means increasing urine output. Now what would be getting better? Once urine is going, is here you're not retaining and you start peeing more. What would happen? Everything will start getting better. Now what will get better here? Your BUN and creatinine is getting lower. Was very high. Now is getting better, going down. And your potassium level would be going down. And your hypervolemia, you start lowering. Now again, when you are in a diuretic stage, again you monitor for blood pressure. What would be the problem with the blood pressure? They're dropping the blood pressure, hypovolemia, and phosphate level and calcium level. So what is second stage is? Number 1, oliguria. Second stage is diuretic stage. What is diuretic? They're stabilizing. That means you start treatment, patient is getting better. What is the third stage is called recovery. What is recovery means the kidneys are returning normal, but sometimes the kidneys are really bad. It might take maybe 1 year, 2 years to really normalize the kidneys. Are we clear? So everyone is okay. What is acute renal failure? There is a precipitating factors. The precipitating factors means something else is causing kidney failure. Patient is in burn condition, cardiogenic shock, and all of a sudden, what do you monitor? Urine output. What happened to the patient is oliguric. What is oliguric? Remember the word glomerular. Inside the kidney, the filtration rate. What is our kidney does? Filtration. Filtration rate is low, and what is high here? BUN is high. What is high here? Creatinine. What is high here is the potassium and phosphate, and fluid patient is retaining. What is low here? Calcium. And one of your question can be, where do you monitor for patient who has renal failure, or which patient has low calcium? Maybe one of your answer may be renal failure. Next is diuretic. Diuretic, they start getting better. Everything is improving and recovery. Now, what do you do for your patient who is having renal failure? Number one, they must have Foley catheter. So you can monitor their INO. Write down the word INO is there, highlight, and Foley catheter. Because you want accurate urine output. Patient is in acute, we definitely need to have Foley catheter for better assessment. And what do you monitor? Blood test, BUN and creatinine. And level of consciousness. What happened? Your patient is going in when your kidneys are bad. The word we use is called uremia. Underline the word uremia. Whenever uremia comes here, means the uric acid, because the kidney is making it higher, is affecting the kidney. And next word is monitor for infection, monitor for wheezing. Why? Because they're retaining fluid. And what is the word would be? You are listening is the crackles and the problem in breathing. And fluid overload. Write down there. What do you assess? Not all your questions are going to be the weight. What do we assess when patient has renal failure? Maybe the lung sounds. Why? Because you are retaining more fluid. Moderate protein. When the kidneys are bad, they don't like to use the word restrict or not to give, is a moderate protein. And also carb, you can give for energies carb, but what do you restrict? They're retaining fluid. You always restrict maybe sodium, maybe in your question, or potassium. So potassium was very high, and when you're retaining fluid also, what does is here, monitor the sodium level. And also be alert, underline the word nephrotic, and write down the word nephrotoxic. Whenever they give you nephrotoxic means the kidneys are bad and is affecting the kidneys. Now patient has nephrotoxicity. That means kidneys are bad. Patient is taking some medication and you avoid to give nephrotoxic drug. Nephrotoxic which damages the kidney. And those drugs you don't want to give because your drug has to get out from your body through the kidney or through the liver. Are we clear? So if these drugs, and there are drugs, and we will be talking about that, those drugs are damaging kidney and you already had kidney failure, you don't want to give those drugs. Maybe something else the doctor would prescribe which is not going through the kidney and will not affect. So in your question, patient is taking nephrotoxic drug. What lab are you going to look here? Is again your creatinine, your BUN. So remember, what would be high here? Some of the medication they're throwing and they will say, what in your question, and they will say, what do you monitor? You're giving this medication. They didn't give you the word nephrotoxic and they gave you the lab. And what lab are you going to notify? Remember, is the creatinine. Creatinine is really shows your kidney. BUN is also sign of kidney, but could be dehydration. It's not the lot of filtration and inside the kidney. But this, if you have both of them, pick up always the creatinine. So how do you know your kidneys are getting bad? Your blood level are high. Uric acid we should know, BUN we should know, creatinine we should know for renal failure. Next is chronic renal failure. Now what is the meaning chronic? There is something going on with the patient, that means they have other problem and they can lead to what? Chronic renal failure. Now what are the reason are? Underline the word acute renal failure. Patient keep on getting acute attack. They keep on getting sick with maybe cardiac problem. Or patient has another problem and affecting the kidneys. Any repeatedly acute renal failure, what does it lead to? Chronic renal failure. Second, diabetic patient. Very, very important. We all should know your diabetic patient, your hypertension. You've got to control your blood pressure, and you've got to control here is the blood sugar and blood pressure. Very important in our teaching. Your questions are more teaching. How do you prevent patient not to go in renal failure? Diabetic patient, they need to control their blood sugar. Are we clear? And that damages their blood vessels and damages their kidneys. Next is obstruction. Means is stone, renal stone. Infection. Patient is having repeatedly infection. Now, which patient they will attach on this question are, which are the patient do you think has repeatedly UTI? Which patient has, remember? Neurogenic bladder. Which are the one neurogenic bladder could be? Your multiple sclerosis, spinal bifida babies. Are we clear? So your questions are anybody who's getting too much of renal problem, too many times UTI, eventually it will happen to them, their kidneys will shut down because repeated attack of UTI. See how your questions are going to be. Not what is UTI, not what is renal failure, which patient are you going to prevent them getting renal failure? Which patient are you going to prevent them? Blood pressure, diabetic patient, repeated infection. If you have Foley catheter, every time we are inserting in and out catheter is leading into infection. Renal stone can lead to infection. Immune system. Anybody's immune system can lead to on that because their immune process. Now, everyone should know renal failure. What are the main reasons for renal failures are? Hypertension, we all should know, diabetic, and repeated acute attack of infection and obstruction and immune system. Next is, I will move on, sign of chronic renal failure. Now we all know it's a chronic renal failure. They didn't word it chronic word, and they say patient is going in renal failure. Now this one also they have stages, but in the stages I want you to highlight the word stage 1. What is the meaning? Stage 1 is early stage. And they may word your question, what are the signs of early stage of renal failure? I want you to underline the word. Second line, nocturia and polyuria. So what is early sign of renal failure? Nocturia and polyuria. What does it mean here? The kidneys are getting bad and no accumulation of metabolic waste in the first line. The meaning BUN and creatinine is not high. Why? Because they're still peeing. So what is early stage of renal failure is polyuria and nocturia. In this stage, I said no accumulation. Your blood test is still showing okay. But what is the problem? We all know patient has a lot of UTI problem and patient is having polyuria, nocturia, early sign of renal failure. Everyone is okay? Early sign of your chronic renal failure. If they didn't give you chronic word and they're saying, what is early sign of renal failure are nocturia and polyuria. Second stage, highlight the word now. They will say, what is the sign of renal failure? You didn't have nocturia. What are the other signs? Now kidneys are really getting bad, and highlight the word oliguria and edema. Are we clear? And maybe the word is generalized edema, or maybe patient is having edema. So what is the sign of renal failure? They didn't say acute, chronic. What is the sign of renal failure? Immediately we say oliguria and edema. Patients start retaining more fluid. And third stage would be final stage, which is called end stage of renal failure. And what is that meaning is the kidneys are really bad, they're not functioning. What do you monitor here? Excessive accumulation of metabolic waste. What is the kidney does? These are the wording they would love to use in your question. So we got to understand your body is metabolizing, and whatever body doesn't need has to be off from the body. So what is the kidneys does? Your body, what is not needing is removing. And that what happened when kidneys are failing, they're not going out and they are increasing in the blood. So what is increasing here? Excessive metabolic waste. That means your BUN and creatinine and uric acid is going to be high, is the wording. So what is high here? Metabolic waste. So what is kidney does? Just put in your mind, kidney filters the urine. Kidney is removing metabolic waste. Everyone is okay? And what are the metabolic waste is? Your body is producing, your body is eating protein, and all that part, what should be getting out is staying inside the body, your uric acid and your BUN and creatinine. Next word, I want you to underline the word homeostasis. What is the homeostasis word is? Your kidneys are balancing your body from external, internal, your body, metabolizing afterwards and removing and maintaining your body in a normal stage. What is homeostasis? Means normal. Your body is maintaining normal. Why? Because they remove what your body is not needing. And what happens if you don't remove? Patient is going in what? Metabolic acidosis. Are we clear? So how do we get is pH of your body? Bicarbonates from your body is not going out. So what happened your kidneys? Which are the two organs maintaining your body and making a balance for your acidosis, alkalosis? One, kidney. Second, your lungs. Are we clear? So how do you maintain your acidosis, alkalosis? Are because we start retaining more hydrogen ions and we start retaining bicarbonate. So remember one thing, your kidneys are failing, patient is going into metabolic acidosis. Are we clear? So what is kidneys are doing here is maintaining the balance of your body and is called homeostasis. That is the balance. And what is the waste from your body are called metabolic waste. Are we clear? What is the main wording here is your patient is retaining. What is renal failure without even having a book? Immediately we know. What is patient is going in renal failure? Patient is retaining fluid. Are we clear? What is the body is increasing here? Metabolic waste. What is it increasing here? Your BUN, creatinine, and I said phosphate and body fluid, you're retaining more. And patient is not able to maintain your body fluid and not able to maintain homeostasis, patient is ending into metabolic acidosis. What do you monitor when your patient is in renal failure? Metabolic acidosis. I will move on. The word is dialysis. When patient has renal failure and your BUN and your creatinine, everything is high, then how do you treat your patient for renal failure? Now, when they're saying end stage of renal failure, that means you cannot manage more with the medication or diet, something else has to be done. And a lot of time, when do you put your patient on hospice? End stage of the disease. Everyone is okay? Patient choose. I don't want to go for dialysis. I don't want anything to be done. I know my kidneys are bad. I'm signing for hospice care. That's okay. That's the patient decision. But when you can maintain and immediately patient can be saved their life and would be the best is they will start on dialysis. Now next is on dialysis. Intervention. Patient is going kidney failure or when they are end stage, remember protein. What do we cut down here? Protein and moderate protein. What do you increase here? Carb. Why? Because they do need energy and you can give more carb. And what do you cut down here? Phosphate. And also I want you phosphate and remember potassium. You're not giving a lot of potassium. Now I'm just going into what would you see when patient kidneys are bad or they're going for renal failure question. Number one, they have a lot of stomatitis, the mouth infection. And underline the word in the same line, very, very important, activity intolerance. Why? Because underline the word fatigue. They're very tired. And why they are tired, we'll go on the next page, is why does the patient feel tired? Is number one, anemia. Everyone, we must have us that we know certain question without even looking. Kidneys, metabolic acidosis. What diet we are cutting here? You must know moderate protein you're going. What do you monitor patient for activity intolerance? Because they are anemic. Why? Because your kidneys are maintaining your red blood cell. So next function of kidney, underline the word erythropoietin. Erythropoietin means production of red blood cell. So what is the kidneys are doing here is producing the red blood cell. When kidneys are bad, it decreases second line, hemoglobin and hematocrit. So what is patient who is in renal failure? They are very low, they are anemic. And what is low here? Hemoglobin and hematocrit. How do you treat them? How do you treat them? By giving them apogen. Underline the word and procreate. And what does apogen does? Increase the red blood cell. Whenever you have question with anemia, we give the patient folic acid. So highlight that word. And iron orally. When you give iron, monitor for constipation. They may need stool softener. Maybe patient would also need the blood transfusion. A lot of time they give them blood transfusion because they are really very bad anemic. And apogen, everyone should know for your exam, and procreate. I want you to write down the side effect of apogen is hypertension. So monitor for hypertension when you're giving apogen. So number one, everyone would know is one of the side effects is here is the anemia and intolerance activity. Number two, GI bleeding. They're bleeding internally, maybe in GI. Why? Because urea is breaking down by intestinal bacteria to ammonia, and ammonia is causing bleeding. So highlight the word, because of urea is high, it affects ammonia level, and because of ammonia they can bleed. So check for occult stool. So monitor for maybe the bleeding disorder. Number three is very important that potassium level is very high. And how do you lower the potassium level? For your drug question, K-axylate. Underline that word, K-axylate you're giving to lower potassium. Second thing you can do, 50% dextrose in saline, and I want you to add their regular insulin. They can add regular insulin with dextrose, and they can give them IV to lower potassium level. That's another treatment to lower the potassium level. And then you will go loop diuretics. What is loop diuretics are? I want you to write down the word Lasix. What is another word for Lasix is furosemide. Furosemide, sometimes they use the word, and that is Lasix. So why do you give Lasix right away? So they can pee more and they can lower the potassium level. So Lasix is furosemide. Furosemide is Lasix, and you are giving IV and Y to lower the potassium level. So everyone should know, no potassium sparing diuretics you will give here because they already have high potassium level. And what are the two drugs are for your potassium is high? I want you to highlight the word aldactone and diurinium. So what is high here? Aldactone and diurinium. This is potassium sparing. That means they won't lose potassium. Potassium would go more higher. So do not give, what is the three treatments I said to lower potassium is K-axylate. Number 2, you give them regular insulin with dextrose. And number 3 is Lasix. And those are your answer to lower the potassium level. We should take a break for 10 minutes and then we'll continue.